Okay, so patient shows up with DKA. So let's say patient X is, I don't know, usually a young person, 32, male, presented with, I don't know, nausea and vomiting. Okay? First of all, how do you diagnose DKA? How are you gonna diagnose DKA? Most of these patients will present either they're unknown to be diabetics, or there is a question mark history of diabetes, type 1 or type 2, right? But usually type 1, because DKA usually presents in type 1 diabetics. So this patient presents with nausea and vomiting. So as usual, what's the first thing you're gonna do, like in terms of labs? What are you gonna order? The simple stuff.
CMP.
Okay, so CBC and a CMP, right? And usually these patients, CBC might be normal, and then the CMP. What's the magic value you're going to be looking at to determine if this patient is in DKA or not? Do you know? So first of all, DKA is diabetic ketoacidosis, right? So typically you have to have diabetes, you have to have ketosis, you have to have acidosis. And the ketosis is the acidosis, so it's ketoacidosis. The ketosis is causing the acidosis, okay? And what type of acidosis is ketoacids? What type of an acid-based disturbance that ketoacidosis cause? I'll make it simple. High anion gap or low or normal anion gap? So
high anion gap metabolic acidosis.
Exactly. So it's a high anion gap metabolic acidosis. Okay? So when you have high anion gap metabolic acidosis, the three things, I mean in the hospital in general, there's, not mud piles, I forget. They have like different mnemonics for it. But in my opinion, the three things you should know for a high anion gap metabolic acidosis in the hospital is number 1, lactic acidosis. Okay, so your differential is lactic acidosis. Number 2 is ketoacidosis. Okay, and ketoacidosis is 3 types. You know the 3 types of ketoacidosis? One is DKA, easy. The other one is alcoholic ketoacidosis, and the third one is starvation. Okay? And then finally, the third differential on your mind for a high anion gap metabolic acidosis is AKI, which is uremic acidosis, essentially. So the magic value for somebody who presents with what maybe is DKA is the anion gap. And keep this in mind, okay? Keep this in mind, that when you're treating the DKA, you are treating the anion gap, okay? You're not treating the acidosis. So the extra one you will do for this patient is an ABG. Okay? So these are the main things that you're gonna look for in this patient. This patient presents with nausea, vomiting, whatever you're suspecting maybe DKA, you'll do the CBC, CMP, and ABG. Okay? So once you determine all these, then you're gonna, in your mind, you're gonna kind of say, I'm gonna manage this as, by the way, some hospitals have a DKA protocol. You can just be like, okay, this DKA protocol, and then, this makes everything easier, right? So you can either do a DKA protocol and then manage in EMR, okay? Now, some hospitals don't have it, and you need to manage it yourself. And so the steps of managing DKA is, first, you have to prove it's DKA. How do you prove it's DKA? So first, you have high anion gap. Okay? Then you have low pH. And it's what? Metabolic acidosis. Okay? What else? How else can you prove it's DKA?
Ketones.
Ketones. So which ketones are you gonna test?
The urine ketones.
So you can do the urine ketones, but more important, blood ketones, keto acids. And these are two. There's acetoacetate, and more importantly, there's beta hydroxybutyrate. So generally, this is the guy you want to keep an eye for, because this is the guy that causes the acidosis. Okay? So when you're managing these people, I used to have an attending who used to tell me the management of DKA is AKD. You know, you want to manage the acidosis, then manage the ketones, then manage the diabetes. But in general, it's kind of classified into multiple arms, as I showed you in the up-to-date algorithm. And it's very simple. If you follow the algorithm, it's so simple, but in your mind, you have to understand the following. First of all, there's IV fluids, okay? So these people are usually extremely dehydrated. They need IV fluids like anybody else, and they usually get enough IV fluids, okay? And the type of IV fluids usually depends on the sodium levels and depends on the potassium levels. Okay? Now what's kind of important for you to know here is this potassium levels, right? Why? What's happening with potassium when there is no insulin? Is it outside the cells or inside the cells? What do you think?
It's leaving the cells.
So insulin causes potassium to get into the cells. When you're insulin deficient, you will have high potassium, okay? But this high potassium is pseudo high, right? Because you don't have insulin. Once you give insulin, all this potassium is going to shift into the cell. You might induce severe hypokalemia. So think of it as pseudo hyperkalemia, which means the levels at which you're going to act on this potassium is shifted to the right. You know, like you're gonna replete potassium even when the levels look normal. Okay, so that's a very important thing. And again, if you look at the up-to-date algorithm, it's very simple. They tell you here, you can look at the renal function, but the important thing is how to manage the potassium is a little bit different than how to manage the potassium in somebody who does not have DKA. Okay, so these kind of three, they give you these three different scenarios about how much is the level and how much you need to give, essentially. And this is different than when somebody is just hypokalemic on the floor. Okay, so this is very important to know. And before I forget, by the way, what's the kind of the pathophysiology of DKA? Like the exact, like what is the primary problem? So it's insulin deficiency, essentially. That's what it is. It's insulin deficiency, and your body needs energy, and you can't get glucose into the cells, so your body starts going ketogenesis. And so that's why you get ketosis, you get beta hydroxybutyrate and all that. Okay? So the third important part is insulin repletion. Okay? Again, I'm not gonna go into like the exact numbers because usually, how are you gonna replete insulin, by the way? Can you give them like basal insulin? What do you
You
think?
give them regular insulin.
Regular insulin, but can you give them like, how are you gonna give it? Sub-Q, you're gonna give it throughout the
IV
day?
infusion.
I'm sorry?
IV infusion.
Infusion, very important. So here it's gonna be infusion, continuous. So it's a drip, it's an insulin drip, okay? So you're gonna start them on an insulin drip, and you know, you can either usually use regular, what we call the regular insulin, the normal insulin that you use. It's like intermediate acting, and you do it as continuous infusion, okay? Now, honestly, I feel like the IV fluid management is easy. The potassium level management is easy. The insulin repletion, initiating the insulin repletion, so initiating is easy. Stopping the insulin infusion is hard. So when do you stop it?
When there's a normal anion gap,
When there's a normal anion gap, or
and the patient is eating well.
when there's a normal anion gap and the patient is eating well. How about if there's normal glucose? So let's create, you know, two scenarios. So scenario number one, so you've got the glucose levels, you've got the anion gap, and patient eating, it doesn't really matter too much, okay? So if the glucose level is high and the anion gap is high, what do you do with the insulin drip? Continue or stop?
Continue.
Continue, right? This is easy. Okay, glucose level is high and anion gap is normal. What are you gonna do with the insulin drip? So here can stop. Okay? All right, let's hit you with another scenario. The glucose level is low and the anion gap is high. What are you gonna do?
You would continue, but you'll add dextrose with it.
So in this situation, very important. So you give dextrose and then continue. Drip. Never ever stop it if the anion gap is high, okay? And you know, the last scenario would be just if the glucose level is low, anion gap is normal, whatever, give dextrose, stop it, okay? Now, just a quick word about stopping the insulin drip. When you're stopping the insulin drip, you can't just stop it and then not do anything, because the patient usually will bounce back. You know, the anion gap will go down and then they will bounce back. So what you usually want to do is, if this is your drip, this is time, this is your drip. What you want to do if you stopped it here is 2 hours before is you want to give basal insulin before you decide to stop. So continue with 2 hours after you give the basal insulin, especially if the patient is eating. So here patient is eating, anion gap closed, right here. Then what you do is you give the basal insulin, you wait 2 hours, then you stop it. And then right here, you get a repeat BMP and you check the anion gap. If the anion gap reopens, then you might need to redo the whole thing, okay? But if if the anion gap is closed, then you're good, okay? Another question for you. So this patient shows up and you're in the ER, and this patient has all these. Where are you gonna admit them? Floor, step down, ICU. What do you think?
I think they need telemetry.
Tele. Okay, so floor with tele. Man
Yeah.
says ICU. Remember, these people on an insulin drip. You're starting an insulin drip. Insulin drip essentially is ICU only. Okay, so these people with proven, so if proven DKA and needing insulin drip, needs ICU admission. And it's going to be the easiest admission for you in the ICU because it's all protocolized. You're just going to put the order set and you're going to follow the anion gap every 2 hours or every 4 hours, whatever. And then it's going to be easy. Once the patient is out of DKA, it feels good. You know, you're like, I managed this patient successfully. They're out of the ICU. So once this happens, then you can, you know, transfer to floor. Once the anion gap closed. Completely closed even after they ate and after you stop the infusion, which means they can go on the floors. Okay, just something extra. Let's say this is the patient first presentation with DKA. Okay, this is just like logistical things. Okay, let's say, you know, ICU treated. Now he comes to you to the floor. You're the receiving team. Okay, what extra things you need to do for this patient? What do you think?
I mean, education about diabetes is
Okay.
the first time. Yeah.
Diabetes education. Again, this diabetes education is actually an order or a consult. Okay, you need to talk to a nutrition consult. Very important, endocrinology consult. They probably will already be following, but you have to, because this is a first timer. He doesn't know anything. They need to establish care with him. They need to know about him so that they can see him as an outpatient. You know, because this guy is gonna need insulin. I mean, it's a type 1. Okay, what else in terms of workup? You want to prove this is type 1 diabetes. What can you do?
You the antibodies.
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 So you send anti-GAD antibodies. And you send anti-insulin antibodies. Again, these things are very important because if they do have them, it's kind of a proof that this is type 1 diabetes. Okay? Because otherwise, type 2 diabetes management is completely different. So you want to at least do these and then make sure upon discharge is that they have insulin, they have glucometer at home, they have the strips for the glucometer and they have the needles for the insulin. Okay? And then they have endo follow-up appointment. Okay, you really have to check that they have all these, or else if you send them without insulin, they're just gonna come back right away. Okay, if you get them to endo, I mean, really the most important part is to make sure that they have their insulin, and to make sure that they have the follow-up appointment with endo. And it's gonna be.
Do we send them to? Sorry. Do we send them to ophthalmology, or does endocrinology do that?
Yeah, endocrinology will take care of that. Unless they're having active symptoms of like some ophthalmologic thing, you don't need to do anything. Endocrinology should be able to send them. From your end, though, you need to get them the education and you need to get the nutrition consult because they're going to have to change their lives. You know, it's a big deal for these people who like get diagnosed. So, and the ICU, in the ICU, they were comatose or whatever, they weren't like with it, and the ICU people don't really deal with this stuff. What happens is that you, as the floor manager, you're gonna be the one kind of tidying up their discharge.